All right. So I'm going to talk about Ferriscan and T2 star MRI in the management of iron overload. I apologize. It's going to be slightly technical because there are some technical details that need thinking about when you interpret the results, especially of the T2 star MRI. So what we're imaging essentially is iron, which is hidden in the cellular ferritin in the tissues, as well as in its degradation product, which is hemosiderin, because both of these are paramagnetic. The other parts of, let's say, iron content are not visible, although they're quite important. For example, labile iron pool. To some extent, we could see it if we linked it with a chelator, but that's not done. So where are these iron sources? I'm going to talk about the liver because the dichotomy between Ferriscan and the R2 star imaging is most relevant for the liver. So we're looking at the hepatocyte mainly and the macrophage. So in the Kupffer cells, there are obviously cellular ferritin deposits and hemosiderin in other macrophages in the spleen and the bone marrow. And we can see them also in the cardiomyocytes and in the chromaffin cells of the endocrine tissue. So why would we measure the liver iron? From the iron overload perspective, the most important aspect is, and it's been known for over 22 years now, that liver iron predicts or tracks the total body iron stores. And we know this from brilliant work by Angelucci, who correlated biopsy liver iron with total amount of iron removed from patients via phlebotomy. This was in thalassemia major patients who underwent bone marrow transplantation successfully, so that they could be de-ironed afterwards, and all the iron was removed from them until their ferritin reached normal levels. And he obtained a fantastic correlation with an R squared of 0.98, one you can barely see ever in medicine, I think. So this is one of the main reasons why we track patients' LIC to understand what's their storage iron. There are obviously other reasons to do with safety. We know that patients whose LIC is below 7 are typically free from pathology, and pathology in the liver starts when LIC is above 16 or 17, as this work by Jensen showed. We have transaminitis above a certain level of LIC. And we also know that liver fibrosis progresses if LIC is above that threshold, and then we have the consequences of that, including cirrhosis and hepatocellular carcinoma. When LIC is increased, the chelatable iron pools are also up, as is labile plasma iron, which then links LIC to extra hepatic pathology in the heart and in the endocrine tissue. And for example, we know from pre-chelation era that increased LIC was linked to cardiac iron in unchelated patients, and also to cardiac death if LIC was over 15. So how do we perform LIC measurement? Historically, it was by liver needle biopsy. I'm not going to discuss liver biopsy today. I just want to leave this information with you that the liver iron by biopsy still had a coefficient of variability up to 40%, because it's dependent on how you sample with the needle, the patchy distribution of iron in the liver. So it's worth remembering that there is this thing as patchy iron distribution in the liver. So in the last decade, we've had attempts to establish MRI methods as the gold standard for LIC measurement, and there are two main methods that are in the fore as good candidates for that. There will be more in the future. So one of them is the T2 star or R2 star method, and another is the T2 or R2 method, so-called Ferriscan, with or without signal intensity ratio, but we're not going to go into this. I have a few slides about the principles of magnetic resonance imaging when iron is in the tissue. So basically, an overload in the tissue shortens the tissue proton relaxation time in the so-called transverse axis, hence the letter T in our T2. And the T2 is the value on which magnetic resonance imaging is based, because images will darken with shorter T2. This T2 shortening is mainly due to paramagnetic properties of ferritin ion, as I've explained earlier. And there, you always hear that there's this T2 and R2, or T2 star and R2 star. They are just reciprocal of one another, and there is a formula worth remembering involving 1,000, because one is in milliseconds, the other one is in hertz. So R2 is 1,000 divided by T2, and consequently R2 star is 1,000 divided by T2 star. And if you pull patients together and look at their ion levels in tissue, so as the ion levels are up, T2 star falls. As ion levels are up, R2 star goes up. And so these T2 and T2 star and T2 parameters, we'd say, are actually derived from two different processes. So when you have a tissue in the magnet, you excite that tissue with a radio frequency pulse, and you can quickly, let's say, uncover the T2 decay process, T2 star decay process, or a T2 decay process, using two different sequences. And I just want you to remember these two different sequences that we will be talking about. There's the gradient echo sequence and the spin echo sequence. The gradient echo sequence allows you to derive images after radio frequency pulse, images at each echo time, which are progressively less bright. And so this brightness or signal you can then plot against echo time, and you have a decay curve. And if you fit it, you can uncover the parameter that describes it. It's sort of like a half time of the decay in brightness, and it can be calculated. So it's important that tissues that darken quickly have a short T2 star. Tissues that darken less quickly have a longer T2 star. And for spin echo sequence, it's kind of similar in principle, but there are some details which we don't have to go into. But essentially, again, on spin echo sequence, images will darken at each echo, either faster and then they have a shorter T2, or less fast and they have a longer T2. So this is generally the principle how AN is measured, because the speed with which images darken is related to the T2 star value. So here we have a Diamond-Blackfan anemia patient with a mild AN overload in the liver. You can see that the liver is bright and progressively, as the echo times increase, gets darker. But if you have, for example, sickle cell patients with moderate liver AN overload, this darkening happens sooner, and if it's severe, essentially the next echo time has it equally dark as the last echo time. This is an important issue, and I'll discuss that a little bit later. So we have these two methods, the spin echo R2, which is Ferriscan, and the gradient echo, which is R2 star. These methods have, for more than 15 years now, been already validated in that they have been calibrated to liver biopsy. And in several studies, I've shown a few here. You can immediately see that they are not calibrated in such a way that there is just a straight line, but there is always this prediction interval, which you can think of as an let's say as a measure of agreement. And so John Wood and Tim St. Pierre, they've calculated how these calibrations agree with, so how the MRI measurements agree with the biopsy measurements. And actually this agreement is quite broad, because it's plus minus 50% for the Ferriscan, plus minus 45% for the R2 star in these two studies. And so that's quite a large limit. And so you can think that, for example, 150 hertz on Ferriscan on average means something like 12 milligrams per gram dry tissue, but in the population it could be anything from, let's say, 7 to 20. So this is a large error space. And so this error is not not only attributable or not completely attributable to this patchy liver iron distribution that I've mentioned before, and the fact that the biopsy may have sampled it more or less randomly. There are other issues for which there is this poor agreement, let's say, within the biopsy calibration, and they are to do with individual patient-specific deviations. So let's just park that for a while. What happens if you actually compare these two methods, so R2 and R2 star LIC methods, in a head-on comparison? What happens to the agreement? So this was done for the first time in 2014. It was done by us and by John Wood when Ferriscan was more or less available. And John Wood found in a group of 51 patients with transfusional iron overload as part of a study, a Ferriscan study, a chelator that never made it to the clinic. He found that there was a correlation, as you'd expect, between these two methods, because they were designed to measure the same thing, so they should correlate, but they actually didn't correlate that well because R squared was 0.75. And on bland Altman, you can see that there was actually a bias, 11% higher in favor of the Ferriscan, and the agreement was dismal. This is actually a log scale, so you cannot see the fanning out effect here. It was between 65 and 190%, the agreement. And when we did this on a greater number of patients, you can, it's not here in a log scale, you can see that the fanning out effect is quite large. So the T2 star LIC and the Ferriscan LIC is here. I mean, there is no agreement. If you do bland Altman, it just changes from plus minus 45% at the lower end to plus minus 90% at the upper end. And even for that lower end, it's not optimal because it's plus minus 45%. So that's not really acceptable. The inter-reporter agreement is typically plus minus 5%. So any agreement limits that are above that suggest that the methods are actually not paired well. And so both of these studies concluded that the methods cannot be used interchangeably when following LIC trends in the same patient, and that one method, so either of them, should be used to follow trends in a given patient. But then again, you know, as far as mean effects are concerned, these methods separately are very reproducible and accurate for LIC determination and over a wide LIC range. So why don't they agree? So in the same study, John Wood very neatly calculated that although cross-sectionally there is lack of agreement, you remember this R squared, longitudinally, when you follow patients in a very careful setting, like a clinical trial setting, when you look at how much they are transfused and how much chelation they take, you can actually be more nuanced about it. So his argument goes as follows. The methods don't agree because they have different sensitivity to the pattern and scale of iron deposition in the liver. And they have some biases with respect to true LIC because of patient-specific differences. You can say that each patient actually has their own calibration curve between their R2 and R2 star signature and the tissue iron. And that depends on where the iron sits inside the cell or in which cell in the tissue. And so random intersubject variability in the calibration is much greater than the precision of both of those methods. And so when you compare these methods, this variability actually adds up. But if you go away from intersubject comparison and look at within patient comparison, these errors kind of cancel each other out, and you have much better agreement. Especially if you contextualize change in liver iron, if you take into consideration transfusion burden and chelation exposure. So John Wood concluded in this study that the chelation efficiency, which is, let's say, a response to chelation on a trial, was much better with the progression of the study, meaning that after 1 year, chelation efficiency was still scattered around the line of equivalence, because chelation efficiency could be calculated using LIC from one method and the other method, so from Ferriscan and from R2 star. But as the study progressed, and then the chelation efficiency nicely lined up on the line of equivalence, or couldn't be different from a line of equivalence. So the conclusion from this is that when you have longer time points, for example, annually or longer than that, this allows for a better agreement in LIC trends between the two methods. And these two methods outperform biopsy in that regard. So how to choose between the methods, or what are the advantages or limitations of these two methods? So the Ferriscan, it's got some important advantages. I think an important advantage is that it's a black box method. So you do this according to the protocol, you send the data and you get the results, and you should be happy. It's an FDA approved method, and which means that it's got big advantage in terms of its worldwide use in clinical trials that have something to do with chelation, where LIC is the primary endpoint or the secondary endpoint. It's got an excellent ongoing data quality control. It's cross-site and cross-platform validated. It uses manganese phantoms to calibrate scanners. And it's got some scope for parallel imaging. They do bone marrow, recently added to the service. They also do the heart, but they use the R2 star within the Ferriscan packet. And interestingly, it's a free breathing technique, so in some clinical context, this can be useful. But its limitations are that it's a long acquisition time. It may involve, therefore, sedation in pediatric setting, and in busy radiology department, this might be an issue. As far as physics is concerned, so curvilinear relationship with the biopsy suggests that if you have higher LIC, then the imprecision of the estimation will be greater. Another limitation is that it's sensitive to fat. So it will likely overestimate liver AN if there is fatty liver. And because it's proprietary and there is complex data analysis, you have to wait longer for the report. And it's importantly significantly more expensive than R2 star. And currently, it's only available on 1.5 Tesla scanners. So that's the Ferriscan. For R2 star, what's for this? So what are the advantages? It's reliable, reproducible, and it's linearly correlated with biopsy LIC. So higher values will not have this estimation error like the Ferriscan. There is many in-house made sequences with post-processing with own calibrations that could be thought of as, and by the way, they are all of them or most of them are free, so this can be considered an advantage. The acquisition sequence differences are correctable if discovered, or negligible, so it's possible to provide reproducible, clinically acceptable LIC estimation. Its most important advantage is that it's very quick. One breath hold is sufficient to provide the LIC estimation. Furthermore, you can do a volumetric acquisition, so you can tell something about the distribution of AN in the whole liver. It's actually robust to steatosis. There are fat saturation protocols that allow us to bypass sensitivity to fat. And it's got greater scope in parallel imaging because obviously heart can be done by the same technique and it's usually done together, but we can also do pancreas, spleen, and bone marrow. Importantly, with the first echo time being below 1 millisecond, LIC up to 20 milligrams per gram dry weight on 1.5 Tesla scanner will be robust. And it can be used on both scanner strengths, the 1.5 Tesla and 3 Tesla, but there are caveats to it, and if I have time, I can discuss that. Now, it's obviously not FDA approved, and that's a big problem because clinical trials tend not to choose it if LIC is the primary endpoint or secondary endpoint. And there is no formal consensus about ideal image acquisition, and you could say that you need a sort of core ion imaging center expertise to produce reliable R2 star LIC estimation. And ultimately, validity of these estimations will depend on MRI sequence parameters. So which method to choose, either R2 star or R2 LIC? I would say that if there is no interest or expertise in ion imaging, it's better to choose the black box method, which is the Ferriscan method. Why? These parameters for R2 star matter, and as early as in 2006, Bugre and others, they've done a simulation study to do with the first echo time, but that was to do with cardiac imaging, so cardiac T2 star imaging. The principle is the same for liver, and this is maybe why it was missed. So they've simulated the data, the R2 star data, by different means to acquire them against true R2 star. And they found out that if you use echo time longer than 1 millisecond, you stop being able to see liver ion above 7. So this is 2 millisecond tracing. You can see that you stop seeing the true R2 star or LIC above, let's say, the mild cutoff of 7. It's much worse if you use your first echo time as a higher time. So if you use 4 milliseconds or 5.5 milliseconds, you completely don't see higher values at all. So that was simulated. And the conclusion from that was that echo time below 1, the first echo time below 1 millisecond was meant to be used so that it detects the true R2 star, or therefore the true LIC. And that was in 2006. So I just want to show you 3 clinical trials to see how this behaved in real world data. So in 2017 at IHA there was a report of a Vietnamese dragon study. I think you may have heard of this, which highlighted and uncovered really unsafe MRI R2 star LIC practice. So it was in Hanoi Hospital, a busy hospital that looked after over 1,000 hemoglobinopathy patients, and they've used a local technique with an online ion health calculator for their T2 star technique, and it was promoted as an alternative to Ferriscan in Southeast Asia, at least. And so Ngoc Trang did this study in 100 patients where they compared the LIC using this T2 star method with the gold standard Ferriscan for trials, and they found out that there were severe discrepancies. A large proportion, around 30% of the patients, were completely misidentified. They were, by Ferriscan, classed as severe patients between 15 and over 40 milligrams per gram dry weight, which on the T2 star method were either classed as normal or mild. And so obviously these patients were denied an increase in their chelation. And you can translate that into the catchment area, and we don't know how many patients were affected by this. So TIFF and IHA sounded alarm bells, and the news went, and I think health calculator is no longer available online, but it just shows what can happen in non-expert sites. They've analyzed the potential reasons for this, and the most important one was the use of published calibration curve, which was generated on site without regard to how the data was acquired. So it's not just enough to use a calibration from published paper, but you need to actually align your scanner to the same acquisition parameters as the ones described in the calibration paper. So during COVID time, there was another smaller study only on 15 patients with beta thal major heavily transfused with poor chelation in Sri Lanka, and they used their own T2 star method, and they used a protocol with the first echo time of 1.3 milliseconds, and they've had 2 years experience with that method, and they used Hankin's calibration. And they used 2 years experience with that method, and they used 2 years experience with that method, and they used Hankin's calibration. And they used 2 years experience with that method, and they used Hankin's calibration. And they used 2 years experience with that method, and they used Hankin's calibration. And because Ferriscan is not available in the standard care hospital, some patients were taken to a different hospital where in the private wing Ferriscan was available, and they found a gross discrepancy between LIC by Ferriscan and again LIC by their own method. You can see that by Ferriscan it was about 20 on average, ranging up to over 40, and on T2 star it was 5 on average, ranging only to 8. And moreover, the relationship was actually negative, which was bizarre. And so I just draw your attention to the fact that first echo time was over 1 millisecond. And so that's a problem when non-expert sites try to provide LIC by the T2 star protocol. And there was another study, just to highlight the issue of parameters, again, in the same year in 2020, it was this time in Texas, 107 patients, mainly sickle cell patients, but also beta thal major patients and Diamond-Blackfan anemia, were scanned using 2 methods, R2 star with the first echo time of less than 1 millisecond, 0.6 milliseconds, using a different calibration by John Wood, but these calibrations that have been published are quite interchangeable, and they've checked against Ferriscan. And you can see that this time there is no bias. In the study above, the bias was about 400%. Here, the bias is negligible. You can see that the correlation is positive and that the points lie mainly on the line of equivalence. But if you look at the limits of agreement, it's actually from 6 to -4, or with 95% confidence from 7 to -6. So if you have a result of 10, you actually don't know if the other method had a result of 5 or 17. So even though you make sure that the parameters are stringently adhered to and they are lower than 1 millisecond, the point is that both methods don't have a perfect agreement, so you cannot use them interchangeably. So we have recently published a guide to how to quantify hepatic iron with MRI, and there is a set of parameters that should be generally adhered to, and they are non-negotiable. And I want to highlight this, that again, the first echo time or the initial echo time is as low as possible, and it has to be below 1 millisecond so that we can trust the estimation of LIC. Furthermore, that the interval between echo times is very short and preferably stable, and the number of echo times is at least 12 or optimally 20, so that the curve fit can be robust, and so that you can trust the parameter of that curve, which is the T2 star. And I'm glad that in last year's British Journal of Hematology guidelines for monitoring of patients with hemoglobinopathies, both methods were actually allowed. So both the Ferriscan and the T2 star method is allowed and advised to be used in routine management and monitoring of these patients. And there is a note for liver iron quantification using T2 star that it must be assessed using the same calculation and cross-validated for results to be comparable. And so now, as far as frequency is concerned, you have to actually look at the previous result that you had before, and it has to be the same method if possible, and you can going forward decide when the patient needs to have it annually, every 2 years, or 6 monthly, depending on the severity. And it actually mirrors a similar situation with the cardiac T2 star. It's based on the previous scans severity. I think I'll stop here, and I'll be very happy to answer any questions.